Hi, this is Patrick Horn, president of GAP. Thank you to our sponsor, Johnson & Johnson, for their support of this Journal Club video module.
Hey there, my name is Alison Moe. I'm a PA with Atlanta Gastroenterology Associates based out of Atlanta, Georgia. I have been a PA with Atlanta Gastroenterology for the past 16 years, really focusing on patients with advanced and complicated inflammatory bowel disease. Today we'll have a call to action and discussion about our GALAXI 2 and 3 phase 3 studies, which were a 48-week efficacy trial of Guselkumab and Ustekinumab, essentially on patients who had previously been on prior drug therapy, and the comparison of the response of those patients on our study. Guselkumab is, again, a dual-acting interleukin-23 P19 subinhibitor, which does have potent effects for blocking interleukin-23 and also binds to CD64, which is a receptor cell that produces interleukin-23. The GALAXI 2 and 3 trials were identically designed. They're 48 weeks, randomized double-blind, and it was a head-to-head drug-to-drug trial. Co-primary endpoints were met in both studies for both Guselkumab doses versus placebo, and both Guselkumab regime of the 200 milligram maintenance dosing and the 100 milligram maintenance dosing demonstrated superiority to Ustekinumab across all endoscopic-based endpoints. So when we're talking, head-to-head, and we want to be talking drug-to-drug, we want to make sure that we have the equivocal patients in both disease state groups. So both the patients in the groups had biologic-naive patient population was around 120. The number of response patients to biologic previous therapy was around 150, and the duration of years of patients with Crohn's disease ranged anywhere between 5 to 8. And the average SES-CD score, which is our simple endoscopic Crohn's disease score, which is what we're using on our endoscopic evaluations, averaged about 12. So we had patients with, significant inflammation, an average fecal calprotectin also that ranged between about 800 and 1200. In the dosing of both Guselkumab and the Ustekinumab during the GALAXI 2 and 3 trials, the patients received the standard FDA-approved dosing, which was 200 milligrams subcutaneously in the maintenance and 100 milligrams subcutaneously in our second group of our randomization. And then for Ustekinumab, the patients got 90 milligrams subcutaneously every 8-week dosing, and then our placebo group. So we consider our primary endpoints to include both clinical remission, endoscopic remission, and deep endoscopic remission. And at the end of 48 weeks with endoscopic response, when we looked at all participants, which included both biologic-naive patients and patients who were biologic-naive, we saw that the 200 milligram dosing of Guselkumab was slightly higher as far as endoscopic remission at week 48, but both doses of Guselkumab were superior to the dosing of Ustekinumab. For example, at our endoscopic response at week 48, the Ustekinumab results were about 37.1% versus about 50% for both doses of the sub-Q maintenance for Guselkumab. Similar for clinical remission, which is a patient symptom-reported improvement, a difference of about 60% to about 76% across all of our participants, but slightly more equivocal in our patients who were previously failed on therapies. And then deep clinical remission, which is, what we want for our patients long-term on therapy, a difference of about 20 to 25% with our Ustekinumab at weeks 48 and week 12 versus about 40% and 37% in our patients who were on Guselkumab. So as far as our call to actions and conclusions, we know that in our GALAXI 2 and GALAXI 3 trials, Guselkumab was efficacious versus Ustekinumab for multiple endoscopic endpoints at week 48. We saw clinical improvements and meaningful benefits for the patients in both the biologic-naive and the biologic-failure patients. And we saw that patients who had Crohn's disease that was severe in disease state and number of years of duration now have an option for if they had been on previous multiple therapies, which is the standard of what happens in most patients with Crohn's. We now have a good viable option to induce improved deep clinical remission based on Gravity 2 and Gravity 3. If you have any other questions or want more details about these drug trials, please go ahead and log on to the GAP website. Have a great day.